Good morning, everyone. Welcome everyone to Sunday Servings 7th edition. This is an education initiative by the Delhi Psychiatric Society to spread academic activities on a lazy Sunday morning, utilize Sunday mornings for some intellectual stimulation. So this is our effort for last 1 year. We're trying to do it on different Sundays. This Sunday, we got a very interesting topic. Dr. Bhaskar Mukherjee from Kolkata will be speaking. And we have three eminent chairpersons from across India. I'll start from, I'll request everyone to please mute, except the chairperson speaker, please mute your mic. So I'll start with, we have three eminent chairpersons. We'll start with Dr. Kaushik, who's our local guy from Delhi. Dr. Kaushik is an additional professor at Department of Psychiatry at AIIMS. He's been working in research and teaching at AIIMS for the last 14 years. At AIIMS' area of research includes digital psychiatry and psychosomatic medicine. And he's been involved in various initiatives. He has been a keen researcher and has published more than 70 research papers and book chapters to date. He's the recipient of G.C. Boral Award and the Brilliant Award for Research Excellence. He has secured competitive grants from various government institutions, and basically is a technology enthusiast, coder, and developer. And research focuses on studying factors that determine the real-world effectiveness of technology-based interventions in mental health. So welcome, Dr. Kaushik, to this interesting Sunday morning service. Our next chairperson is Dr. Amrit Pattajoshi. As you would have already seen, is well known across India. He's from Bhubaneswar, but that hasn't kept him away from the national limelight in IPS. He's very active in IPS on various levels. He's a professor at High Tech Medical College in, if I remember, in Bhubaneswar. He's president of Indian Psychiatric Society Odisha branch, and he's also the secretary of IPS E-Zone. And he's also trying to be secretary of IPS.
जो बन भी जाएगा.
So that's what it is. And he's currently chair of sports and psychiatry. He's also very, very active when it comes to LGBTQ rights and also women rights. And he doesn't stand for men's rights much, but anyways. And also is a very enthusiastic cricketer, and he plays for East Zone. He captained East Zone, and I'll see him again in IPPL in January in Kochi. So that's Dr. Amrit. And and Sunday Servings का जो motivation है, वो Thursday Musings है. वो Amrit और Aleem का brainchild है, and they've been doing it successfully for more than 3 years now. They started in COVID, and that has been a remarkable. For all his faults, this is the best thing he's done in his life, Amrit. I think that's. सारे पाप इसने धो दिए हैं वो करके. I think because that has helped.
Bhaskar will tell it is the worst thing he has done.
मैं अभी भी मेरा व्यू पॉइंट से नहीं हटूंगा.
मत हटो. But I think what both along with the Tufan Pati sir, I think what they've done is revolutionize the way academics is done in India at a very general level. Otherwise, we had to go to institutions to learn. So that they have taken it out. I think that's very good initiative.
That is.
So I should commend them. Good. Yeah. And over to the third chairperson, Dr. Manasvi Gautam, from a very illustrious family of psychiatrists from Jaipur. He's currently director at Gautam Institute of Mental Health Sciences, which is itself a big institution. Spearheaded by Dr. Shiv Gautam, Shiv Gautam was one of the youngest IPS presidents, if I remember, and also one of the pioneers in psychiatry at various levels. And he's following his footsteps. He's trying to fill in. It's not easy to be under a Bargat ka tree, but he's also trying to be Bargat ka tree under a Bargat ka tree. So he's got a big, but he's doing very well. And he's active in various committees. Let me just read 1 second so that I don't miss any of this. And he's also very active in IPS at various levels since I know him for multiple years. He's assistant professor at psychiatry at JNU Medical College, Jaipur, and he has also, besides doing MBBS, DPMD, MD, he's done fellowship in psychosexual psychiatry. He is not mentioned, but I think he's also in subcommittees of, I think 2-3 subcommittees of IPS. So, and our speaker, Dr. Bhaskar, Dr. Bhaskar likes to be a controversial figure in psychiatry. He is, no doubt, because of the views he has. He was a professor in Malda Medical College, but now he's consultant psychiatrist in Kolkata. His basic interest is in molecular psychiatry and psychiatric genetics. And he's been pushing very hard for us psychiatrists to look beyond psychosocial models and focus a lot more on biological psychiatry. And I think this talk today will also try to steer us in that direction. He is the one who doesn't mince his word and is very open about criticizing our thought processes or our dogmas. He likes to challenge them with his provocative speech. So that makes him a much more interesting speaker. And it's not just that he's provocative, but he's also very, very knowledgeable. And the way he links, like I still remember, the way he linked in evolutionary biological stuff to today's symptoms, very, very interesting. I don't remember. I think it was myoclonic jerks, how monkeys had myoclonic jerks as a defensive mechanism so they don't fall from trees, to us having that. I think I still remember that link. It was very, very interesting. So I think his knowledge is very, very useful to all of us. Over to our chairpersons for the opening remarks and comments, and then we move on to Dr. Bhaskar's presentation.
Can I start?
Yes,
sure.
So I think this is the most the most in topic now. If you look at the evolution of the whole classificatory system, it was built on the premises on which people were living. So it started on the psychodynamic theories. There's always a struggle between the dimensional and the categorical views. And if you look at recent researches, you are coming to the brain now. Now the focus of Bhaskar and the current branch of psychiatry is about the brain. And Bhaskar is somebody who will not take any hostage with him. He will, he does not believe in that. And at least what he has managed to do is the people who are the fence sitters, he has managed to convince them to think about things which they never thought about. It's just that people don't like this style, but that's how you can build on. You have a certain belief systems, and you want to hold on to that. You need somebody to challenge those belief systems, give evidence, and now if you look at it, forget whatever papers are coming. Today you see somebody is having OCD. 2 years later, you see somebody is having schizophrenia. Then you start thinking, did I diagnose the person wrongly last time? If you look at majority of the diagnosis, anxiety is a very, very common symptom in all the diagnoses, be it schizophrenia, be it a bipolarity, be it anything. Even substance, if you take out the anxiety, if you look at actually tease out symptoms, you'll start to understand that you cannot tease out anything and everything out of something. So and then we start judging people that he's writing a mood stabilizer, he has written an antipsychotic, he has written an antidepressant. It means he is in league with a pharma company. Nobody understands the results which somebody is giving with his out-of-box thinking. So somewhere diagnosis was something they used to hide behind. Okay, I have written this medicine, so I'm justifying this. And if you look at Western countries, diagnosis was only because insurance wanted a diagnosis so that they could pay back the bills. So ultimately, we were going nowhere. Where actually everybody was trying to protect their own self instead of looking at the patient care. And I think the whole concept that is changing will go a long way in not putting psychiatrists in. You have diagnosed somebody as mania, and I'm telling you, after 3 years, it might turn out to be a schizophrenic illness. Forgive me for using these terms now, but then what will you do in a court of law? One psychiatrist telling this is schizophrenia, one psychiatrist telling this is mania. And now those things will come out in another 1, 2 to 3 years. Academicians will speak of something. They stick to certain things. Because they're in an institute, they're protected by a lot of things. But the practitioners will think of something else. The researchers are thinking of something else. So I think this whole system needs a revamp. But classification systems are important, but they need a revamp. And I think we need to rethink our whole thought process and the teaching what we are doing to a student. We just can't ask ICD and DSM and have a diagnosis that we are not able to fit in anywhere.
Yeah.
Exactly.
Sir, may I take over from Amrit? I'm Dr. Kaushik.
Sorry,
Dr.
yes, go
Yeah,
ahead,
yeah.
please.
Right. So that's a very good opening from Dr. Amrit. But knowing Bhaskar and trying to chair it, we have to, me and Amrit, I think we are going on a debate so as to give a, kind of a opposition view to all the users.
That's exactly why we added you.
Exactly. So essentially, no, I know Bhaskar from a long time back, and he's a wonderful speaker, and he's an intellectual person. So the issue, what Dr. Amrit is saying, we also get the same question from the students. If the diagnosis keep on changing, what is the purpose of all the diagnosis? And to all the youngsters who are out there, you can criticize a diagnostic system after you have read it and understood it. So there are two ways of looking at it, like all the guidelines also, like clinical guidelines, diagnosis, these are made as kind of a ground level stuff. Once you have understood them, you have every right to criticize it. But don't take Bhaskar's or our word as an outright negation that the diagnostic systems do not have any value. That would be one thing to say. I am more interested in understanding from Dr. Bhaskar in a sense, like ICD is more of a conceptual diagnosis, consensus diagnosis.
Consensus.
Few people sat down together and said, okay, this seems to be the best way to fit it. It served the purpose in a sense that you had some criteria to at least identify what mental illness are. That's how I think the IPS and Robinson Goose criteria, all those things came. DSM went a bit further into trying to make it a syndrome-based diagnosis. Our doc has tried to make it onto the research domain criteria based diagnosis. And because none of us have any etiological diagnosis, of course, there is this conundrum. It's more like theorems in geometry, where therefore we need to also know the names. कि इसने ये diagnosis दिया, इसने ऐसे बोला. So that's why names are also important. So with that overall understanding and kind of stabilizing what Dr. Amrit was saying, is that what I think we should take from today's thing is that diagnoses have a value, but at the same time, we should not be blind. It is not dogmatic, but it is more of a pragmatic way in which we should be looking unless Bhaskar makes me think, no, it does not have any value at all. So that would be my opening, and I'll hand over, I think, we have Manashri is there, na? Dr. Gautam.
Yeah.
Please, your opening remarks, and then we hand over to, I think, Dr. Bhaskar. Thank you.
Well, it has been very well started by Amrit trying to push in certain thoughts and by you making it continue. But the main essence still remains the same, that anyways we are looking at an entity which is altogether different how other entities are looked upon in medical field. We talk about functionality at the core, and our diagnoses are all basically functionality based diagnosis. That's the reason why they do not look like normal etiological diagnosis of other pathological illnesses. And that makes it very special as well, because that is the essence of the dynamicity it caters to. And that is the reason why it keeps on changing also, why we say that it changes, because later on once the spectrum changes or the presentation changes, our diagnosis change, which is irrespective of others diagnostic systems where the pathology remains throughout the same. If it's an arthritis, it's going to be arthritis, or if it's diabetes, it's going to be diabetes throughout that. So this is the reason why there are so many things which we can interpret upon, and then definitely Dr. Bhaskar is there to enlighten us. So I won't stay much between the wisdom and the audience, and give it over to Dr. Bhaskar for his presentation.
Thank you everyone for tolerating my delay. Actually, we were going to start at 11 a.m. And the problem was I got delayed in traffic and other things. With this apology, let's go to our topic today. We have to understand that diagnosis has 3 levels of importance in any medical field. Number 1, diagnosis says to the patient that what actually is happening with him or her. That is patient aspect. Number two is diagnosis gives the clinicians, the academicians, the researcher something else. For clinicians, it is okay, I have found this one. This is the usual mode of treatment for this disease, and this is how I can help the patient. For academician, is I have found this kind of various thing. This is the disease. This should have natural evolution like this, and this would end up here. And for researcher, it is okay, we have found a disease. This disease has this further ramification. Let's find out what the ramification are. Let's find out better and improve way of treating this disease. This is the doctor end. Now comes the social and economic angle, and that also includes the policymaker. They say, okay, this is the disease, this much we need to spend as its burden, this much we need to actually do for its treatment, like this much infrastructure development and this thing like that, and this much economic, I would say, compensation or something else we are going to give to the patient. Now let's go to psychiatric diagnosis. What they serve. Do patient have anything to understand or say? If I say this patient has schizophrenia, patient would understand nothing, because schizophrenia by literal definition is splitting of mind. There is no mind. So how can it get splitted? Then can an academician or researcher or a clinician gain anything from getting a schizophrenia diagnosis? They don't know. That clinician won't know anything about how to proceed, because antidepressants could be useful, antipsychotic could be useful, anti-epileptic would also be useful, benzodiazepine would also be useful, various cognition enhancers, they would also be useful. So getting a schizophrenia diagnosis doesn't give clinician any validity. Getting a schizophrenia diagnosis doesn't give any academician anything new. They are still at the same dark. For a researcher, schizophrenia is like a maddening diagnosis, because there is no head and tail of this diagnosis. The criteria doesn't match, anything doesn't match. Then lastly comes policymaker. For them, actually, schizophrenia has meaning. For them, the policymakers, the persons who are giving the economic benefit, the persons who are trying to form a treatment infrastructure, for them, actually, schizophrenia has a meaning. For them, schizophrenia is this illness on which they need to spend this amount of money. They need to do this kind of resource allocation and things like that. But are we dealing our diagnosis to give benefit to policymakers? That is the thing we should think, because patients are not getting benefited. The treatment providers are not getting benefited. It is only for the policymaker which our diagnoses affect. With this introduction, let's go to a presentation. This is actually an old presentation. We are just keeping the presentation as a framework from which we would talk about different topics. We can divide the problem of classification into superficial, not so superficial, and deep. So the superficial problems of making DSM and ICD as diagnostic system is multiple. Number one, in this classification, there is no medical identity. These entities which we diagnose via either ICD or DSM, they don't have any medical significance. If I say this patient has depression, there is no single pathophysiology behind that thing. And ultimately, there is no validity that this person has this, and these features. So this person is going to be a person with depression disorder. Because again, that thing changes. That is the core of our problem actually, this longitudinal stability. Why? Because today we see a patient, diagnose that patient as first episode psychosis, give the person antipsychotic. In next month, the person is going to return with low mood and various other things. And we would term it in old classification post-psychotic depression. In newer classification, antidepressants induced deficit symptom, sorry, antipsychotic induced deficit symptom, or some new nomenclature. But the next month, the same person might come with various obsessive traits and obsessive behavior. We would then give the name OCD. After few years, there would be periods of hyperexcitability, periods of restlessness, talking excessively, as well as aggression and other thing, and we would give the term mania. So the patient gets confused. We also don't know what we are doing. And we end up prescribing everything in our armamentarium in a shotgun manner. That neither help the patient nor help us as a medical specialty. People actually take our branch less and less seriously because of ultimate shotgun. And most of the psychiatrists have to use shotgun because it is impossible for most of the psychiatrists to come into term with these things. They would try to stamp these patients as DSM something, ICD something, and would create bigger and bigger mess. Now, being just a symptom, they would change, and ultimately the natural course of the brain illness would not be actually addressed or treated. If I say to you today that whatever happens, give a patient with so-called bipolar or schizophrenia diagnosis one cognition, so-called cognition enhancer, means memantine, one antidepressant, and keep them lifelong. Would you at all believe me? No. Because today's evidence-based medicine is based on this DSM ICD small categories which won't allow any of you to prescribe that. But these two strategies are actually one of the biggest helps in preventing further neurodegeneration and preventing further episodes. But our current diagnoses and the guidelines won't allow this one of the most effective strategy to even work. I know most of you love Sigmund Freud or have healthy respect for him or have various attachment to him. But the problem is, by nature, he was a scientific fraud. His data is not there. Scientific credibility of Freud has always been in question. His theories, his observations were based on only one patient, Anna O. And till today, we are not sure if Anna O ever existed. So the start of psychiatry, where it started its early signature as a different subject of brain than neurology, is a start based on lies and scientific misconduct and scientific misadventure. Then next one, not only Freud, every researcher who were at the time of Freud, after at the time of Freud, they created multiple scientific problems. Their methodology was flawed and their data was fabricated. And even now, standing in 2023, their papers are being retracted from journals of repute. Eysenck, the most famous, debatably, after Freud, is getting his paper retracted all over the world in all journals of repute. And Eysenck is not the end. Most psychology luminaries who started talking about psyche, who started talking about mind and things like that, they have a very, very murky academic lines. This is one of the just example of how they made some fantastic problems. Like this one is actually Eysenck's research, which is now getting retracted all over the world, similar to all other theories of Eysenck. So at this moment, all the explanation of psychopathology are wrong. So delusion doesn't occur the way they told. Hallucination doesn't occur the way they told. Obsession and compulsion doesn't occur the way they told. So if psychopathology itself has no validity, then how can psychopathology based systems be right? We, when examining the various patients, we rely on psychopathology to come up with the ICD or DSM tag for it. And ultimately, the psychopathological basis is proving a very wrong thing. This is actually a very famous interview of Richard
I think a
Feynman.
kind of pseudoscience, that social science is an example of a science which is not a science. They don't do scientific, they follow the forms. You gather data, you do so and so forth, but they don't get any laws. Haven't found out anything. They haven't gone anywhere yet.
The thing is, I am pausing the video here because I don't know how many of you know how fMRI and dead fish is related. So I am giving some explanation here. The thing is, fMRI software actually have multiple bugs. One of the major bug is it cannot differentiate brain activity of a dead animal and a live animal. So a test was done where a dead fish were put inside a fMRI scanner and then its brain activity was measured. And this gives a serious question that whether the current fMRI, which we do and say this is shown by fMRI that this person has this person has this disease has this, is probably not above question. Rather,
Hello, Dr. Bhaskar.
Have we lost him?
Yeah, I think I lost. I thought I was the one who lost the signal. Dr. Bhaskar, we can't hear you. Freud की आत्मा ने रोका इसको.
What about you?
What about you?
Call,
हाँ,
call करूं?
पूछो. हाँ, पूछो.
भास्कर को एक डेडिकेटेड लाइन देना पड़ेगा. ये अच्छा बोल रहा है.
उठा रहा है फोन, नहीं उठा रहा?
नहीं लग रहा, जस्ट उसका सर्च हो रहा है. बिजी बोल रहा है. नहीं, फोन नहीं लग रहा बस.
कोई, मैं देखता हूँ दोबारा. Dr. Kaushik?
Yeah. So I think, I'll take over. So till Bhaskar gets back, I don't know how long time we have, but still he gets
We
back.
have time.
Let us go with a story in the meantime. What Bhaskar says, the truth is never an absolute thing, but this is a problem that all clinicians or all persons who are working in the field of mental health has been facing. So this story kind of starts at the very beginning in France. So there was this person called, should I fill in or should I?
Yeah, please fill in. Please, please, go ahead.
So what I'm trying to say is how all this started is Philippe Pinel was a medical doctor. He was not from France, but he was one of the hill town.
Okay.
So he came to France, to Paris, to practice.
Mhm.
because he was not from, as usual, from politics, and he was not.
Sorry.
Yeah, Bhaskar, are you back?
Yes, I am back.
Okay, then you
Great.
complete, and
Hmm.
I'll come back later again.
Hmm.
Till he sets up, please continue kar lo. Pineal
Yes,
ki
yes,
story
yes.
if you want to.
Yeah,
Till he
the
sets up
story
again.
was, yeah, the story was that when Philip Pinel was not given any good position, then the
Uh-huh.
mayor gave him a position to look after the asylum.
Hmm.
Okay.
And from
Hmm.
there, the beginning of this query started कि ये जो asylum में इतने सारे people are with mental illness, what do we do
Mhm.
with them?
Yes.
Mhm.
The classifications actually starts from a very pragmatic basis of how am I going to manage these people. So
Right.
after Philip Pinel, then well, we can go on ki how
Hmm.
the situations changed, but essentially now when we are looking at things, we see all the fault, but the initiation was actually, it started from a very practical and a humanistic idea, because Pinel is
Mhm.
thought to have, freed the psychiatric patients from shackle, because there
Hmm.
was no
Hmm.
way of classifying them, and everybody was changed. So
Hmm.
changed. At least he made into a straitjacket. So that's the
Mhm.
initiation of the first spark of starting a psychiatric classification. The rest of the story comes again later when if Bhaskar loses connection again, I think. Back to Bhaskar.
uh, let's continue that. What you started. Actually, once before I go back to my presentation, every classification system, everything that we do in medicine starts from a very well-intentioned thing. But it's the one, actually next generation who has to reform this process again and again. Until and unless we do that, that well-intentioned initial step would actually pave the road to hell, because the errors would keep piling up, and ultimately what we get is a dogma. That is what has happened in psychiatry. The initial point of coming to a diagnosis was to give patients relief, but the way of finding diagnosis was wrong. And in later years, none of the next generations have tried to correct it. They go on digging the hole deeper. First, classification system came into being based on wrong parameter. Then neo-Crepellian actually started using those things to enlarge their agenda, their importance, and push forward their point of view, without understanding that what Kraepelin told and what these neo-Kraepelinians are doing is completely wrong. And then came Engel and his biopsychosocial theory, which he shamelessly stole from Roy Grinker. And from there, he actually owned it. Roy Grinker was the person who invented biopsychosocial theory. His idea was to resist again the aggression of the psychoanalytic lobby. He was trying to make psychoanalysis lobby take a back seat and make psychiatry more scientific. But when Engel took that biopsychosocial theory of Reiginger without giving him due importance, Engel changed the direction. Engel tried to push various psychoanalytic theories within his biopsychosocial theory. And ultimately, Engel was resisted by his own medical colleagues. They just didn't accept any of his things. But in psychiatry, Engel found sympathetic listeners, and Engel found fellow beings who are in nearly same boat. So neo-Crepellians and Engel, they talked, they discussed, and they gave these names. Anxiety. Anxiety was never a diagnosis before that 1970 to 1980 period. Similarly, dysphoria. Similarly, dysthymia. Similarly, even current depression. They are all product of those compromises and those political maneuvering that happened between Engel, psychoanalysts, neo-Crepellians, and others. With that, I am again going back to my presentation. Actually, next part of my presentation is on that. Kreplin's, when started his dichotomy, Kraepelin gave his dichotomy an explanation for only major psychosis, and as he understood standing in his time. Kraepelin was a very good observer. Kraepelin was a very good, I would say, phenomenologist. He saw the phenomenology, he classified the phenomenology, he understood that phenomenologies are not matching, and he could trace out two different way of disease progression of a single thing. Then he put forward his own biological theory, which is actually pretty good standing in his time. In 2023, if I talk about Kraepelin's theories, I would find a lot of loopholes. But standing in his time, Kraepelin did a wonderful job. The founders of DSM and ICD were ironically neo-Kraepelinians. According to their self-declaration, they extended these theories to a lot of names they invented or rather borrowed from common language. All the dysphoria and other things, they are part of that effort. Depression never existed before, so was anxiety, panic disorder, phobia, obsessive compulsive disorder, the all-pervasive trauma of psychiatry and its associated disorder like PTSD, stress reaction, all were created and made into nosological entities by neo-Kraepelian in their political nosology system. It is a political nosology system, but I am not going into that political history. The name of these disorders actually picked up from common language. That is why that added another problem to the burden, because if a person says I am depressed, then the problem comes if the person is describing their low mood state, or if the person is describing a disease symptom, because of this common language origin of these terms. This is a good paper by Nasir Ghemi, and as I progress into the presentation, you would invariably notice that I and Ghemi, although we represent two different spectrums of thinking, are actually agreeing on many of the ways. He is more into psychosocial and psychiatric epidemiology, me more into genetics and brain, but both of our dissections of classification system coming to a same level, because neither from his point of standing nor from my point of standing we are finding anything logical in the nosology of psychiatric disorder at this moment. Now, dreaded deep problems, and the deep problem is really what matters for clinicians like us. There is no way to prove existence of any entities. So all the studies that uses these nosological entities to find treatments for them are becoming pointless entity. If I say escitalopram, fluoxetine, and along with that paroxetine was given to this group of people who have depression and they improve, what did they do to improve them? If, and it's a very large if anyone ever tried to give olanzapine low dose or quetiapine low dose to a patient of depression, so-called depression and nothing else, then the person would find out that these people would again improve on these drugs. If we give no other drug, then too they would improve. So does that mean olanzapine, quetiapine becoming antidepressant or something else is happening? So we have really made a mess of treatment because the treatment itself is getting diverted. We don't know what we are treating, and so we can justify giving everything. We cannot justify giving anything if we go via this way. All the neuroimaging studies which are focusing on seeing brain changes in these baseless neurological entities are proving themselves non and replicable, no, wrong and non-replicable, because they are finding similar patterns in everything. If I talk about neuroimaging of depression, there would come hypofrontality. There would come low level of metabolism or low level of blood flow, depending on whether I am using PET or fMRI in anterior cingulate, in various areas of temporal lobe, in parietotemporal junction, in superior cerebral peduncle. Now, if we place a patient of OCD under the same scanner, the same thing would come. Then let's take a negative symptom patient. The same thing would come, along with possibly more areas would be highlighted in temporal lobe. And then we take a patient of anxiety, same areas would be highlighted. Dementia, specifically frontotemporal dementia patients, almost nearly same areas would be highlighted. And how can we then say that these changes are due to this thing particularly? We cannot. We don't even know these things. And the biggest damage it has done is the concept of normalcy is gone for a toss. We can prove any person ill at any given point of time if we apply the DSM and ICD criteria. Let's say I I, I am going for some walk, and I got robbed as well as beaten. I would feel low. I would feel a lot of things for at least 2 to 3 weeks. In DSM criteria, that makes me a suitable candidate for depression. Same is true for grief. Same is true for everything that we diagnose. If anyone wants to search for hallucination in normal patients and non-psychotic hallucination in Google Scholar, they've found a huge number of papers describing hallucination in normal patients. Similarly, all the symptoms that we use to diagnose either schizophrenia or bipolar or anything can be found in a lot of normal people. So where does normalcy stands? Is there any normalcy? If we are seeing a patient and we are just tagging DSM ICD criteria, how can we be sure that this patient really has something and the family is not fabricating? We cannot. Just good faith on family. That is where the deep problem starts, along with the destruction of scientific things. All brain have multiple complex cognitive, behavioral, somatic, and sensory motor traits, and each of these complex traits are again formed by thousands of smaller normative. I would say normative because normally these small traits would be found in every people. Normative, more specific trait. So by working with these imaginary colloquial language based nosological entities, we are trying to divide water of an ocean with floating nets. This has ended almost all scientific credibility of psychiatry and our research results. Similarly, genetics, epigenetics, omics, microcircuits, local circuit, large scale network, everything are same for all the psychiatric illnesses, so called. And treatment is the biggest casualty of this. If almost all nosological entities are colloquial language term, then how we are making a drug antipsychotic, something antidepressant, something antimanic, and so on? How can we do that? And that makes prescribing this drug into something redundant. I am saying just that connection is there or not, because I am a bit scared that connection might go. Okay. So pardon for the distractions. Ultimately, all the drugs, be it olanzapine, be it risperidone, be it escitalopram, be it venlafaxine, be it anything and everything, they are drugs which work systematically and cerebrally, affecting every biological activity. So why make them limited by DSM and ICD names and associated scaremongering? Why I cannot give olanzapine in a patient of attention deficit who is experiencing low mood because of restlessness, because of inability to concentrate? If I give olanzapine to this patient, the patient would feel better. Why I cannot give it? Why there are the guidelines that condemn this use? Why a person who is having active hallucination cannot be given anti-epileptic if all other methods fall, because anti-epileptic by definition are drugs which reduces neural transmission. So hallucination formation, or if I may, obsessive auditory or visual imagery formation is created by hyperactive neural network. If we dampen the neural network, then they would get reduced. So why cannot we give anti-epileptics in so-called resistant hallucinations? You see, I am giving the scientific rationale why we can give them, but there is no practical way of giving them without inviting criticism from all the HODs sitting in their pedestal of golden chair in institutes, because for them it's a serious level of problem. So ultimately, what is happening? New students and all qualified psychiatry professionals are being made to write drugs based on imaginary conditions, with imaginary restriction, with no regard to lives and betterment of patient. In NHS, in US Medicaid system or Australian system, you cannot write a life-saving drug. For example, let's say if there is aphasia, methylphenidate is perfectly suited to treat that aphasia. Post-stroke aphasia responds to methylphenidate beautifully. Can you write that in the system of USA or UK or Australia? You cannot, because that is criminal malpractice in their system. In various disease, for example, let's say a borderline who is self-cutting himself or herself, a borderline who is endangering himself or herself via risky impulsive sexual activities, can be very well managed by naltrexone. But writing naltrexone is a crime in Australia or UK or USA for this type of patients, because evidence medicine doesn't support it. You see the problems we face. And evidence-based medicine of psychiatry is zero at this moment, again due to these diagnostic problems. We follow the forms of statistical analysis of science without finding any rules or methods and obviously meaning behind it. Just 5,000 or 10,000 patient data, nothing more than that. And that is being subjected to statistical torture, and we are finding trends because we are torturing the data too much. And then that trends we are applying for 8 billion plus people of this world. 10 to 15,000 data is which is based on nothing scientific or logical, is guiding treatment of 8 billion plus people. Is that justified? That is not in any sense of science. So this is the deeper problem of this all systems. So with that, let's give you a live example. Behavioral addiction. We are now highly interested in diagnosing various behavioral addiction. Every couple of years, we are finding new names, we are giving them scientific validity, and we are treating them. And I am hoping by end of this decade, we would find life as a behavioral addiction. But problem becomes is human tendency to explore, human tendency to give a balanced, unbalanced choice cannot be controlled by that. Means, let's say today there is a final of World Cup. Most of you, if not all of you who are listening, are going to see the match and you would cheer for India. Why? Why would you cheer for India? Because your brain's faulty cognitive algorithms say that you identify yourself as Indian, and due to being Indian, you are obliged to support India. This is how our brain's logic system work. It is faulty, it is biased. It would always be biased. Human bias is inevitable and eternal. So if human bias is inevitable and eternal, and human motivation is also biased, then it is natural for all human beings to do one thing or other excessively. When it becomes disease, when society says it is a disease and we don't like it, does that make a scientific disease? In 1700 media, if anyone wants to search, they would find out there is a term called novel addiction. That was purely society's view of young people spending their time reading various novels. Then in early 20th century, there was paper addiction. Again, social views on a disruptive technology that is actually taking over human daily habits. Then radio addiction, then TV addiction. When I grew up, at that time, TV addiction was a rage. Then mobile addiction, internet addiction, social media addiction. And again, it is a social term, but unfortunately, this time there are medical professionals who are backing it, who are making it a disease, and who are subjecting people to treatment because of their faulty scientific reasoning. That is how behavioral addiction is an ideal example of deeper problem of our nosology. We created nosology because of society demands it, because of science demand it, no, because of medical ethics demand it, no, because our biomedical knowledge says so, no. We create disease entities because we are henchmen and bouncers of society. So what's the solution? There are three ways. Either reject DSM and ICD and create our own Indian system of nosological research, which would again be another set of dogma. Keeping DSM or ICD and understanding they are useless scientifically So side by side, improving scientific awareness, knowledge, and discarding the imaginary nosology one by one, or going back to basics and start from zero. 1 and 3 would be meaningless at this point. Although China has created its own classification system, Japan is creating, Korea is creating, that is not going to be a permanent solution, because human bias would again be there, and they would create a few, I would say, problems similar to DSM and ICD. So going back to basics and start from zero, although is very appealing and is probably the most logical thing to do, is not possible. Because we don't have that much time. We have to give patient treatment currently, and there is no way we can junk all the system and say to patient, भाई मेरे पास कुछ नहीं है, ये हम लोग जो बता रहे हैं वो गलत है, सही क्या है पता नहीं है, तेरा क्या है पता नहीं है. Patients would get panicky and do a lot of misadventures. That is not going to help anyone. So we have to keep DSM, and then we have to understand they are scientifically inaccurate, and so we have to do parallel research. This is actually would have been the process if we started from discarding and started from zero. Initially, I don't know how many of you have read about Maclean and his mammalian system, or he proposed that basal ganglia, midbrain, and brainstem are due to reptile inheritance of ours. Hippocampus, amygdala, olfactory tubercle are due to early mammals, and neocortex is due to new mammalia. His idea initially was that it is due to anatomical formation, but later we observed that all the brain region develops simultaneously, so it is not an anatomical qualification, but ultimately that corroborates with functional categorization of brain. And so in 1998 developed categorization of Maclean, and then the same network model of Panksepp developed into ArtDoc differently, and behavioral phenotypes are being formed and other things. So there is a way of discarding and starting from zero, but this process is very slow, and this process is not getting applicable to clinics in any time soon. I am not seeing ArtDoc giving any fruitful result in next 20 years. So keeping and researching is the best option. Here we match various traits from how they are formed: neurohormonal, environmental, vulnerability, genetics, and these traits are joining to found various behavior.
Bhaskar, your network is getting unstable. Your network is getting a little unstable.
Okay. So I have already finished. Can
you repeat? Because the last two slides were important. Can you please go back and repeat them? I think that'll help a lot of people. The two steps, the way forward you said. No?
This
go
one.
Back. Go back. This one. Keep it. Just say that.
Yes.
Can you stick with? Can you repeat this, please?
Yes, yes, yes. So the way forward is three type. One is going back to basics and start from zero. Problem is, it is not possible at this moment. Am I audible now?
Right. Yeah, you're audible. Why don't you stop your video?
Vishal?
I think that'll. Yeah,
Am I
you are
audible?
audible. Yes, you are. You are audible.
Yes.
Can you stop your video? I think if you stop
I am
your video
stopping
for
the
some
video.
time.
That is
No, your video, not.
Yeah.
I
Yes,
think
I am
slide
doing that.
stopper. Okay. So just to repeat what you said it's not.
Stopping my video. Just a minute.
Yeah, no problem. So what you said was, instead of going back to scratch, because that will take around 20 years and we'll be at nowhere, we stick to the ICD and DSM and continue researching side by side.
We have to stick with ICD and DSM, and we have to improve them by instilling our current scientific understanding in them and creating research side by side to come up with a solution. And that is going to be the last slide. I'm again actually sharing the screen.
Yeah, please. I can stop your video from my side. I think that'll stabilize. Let me stop your video. Yeah. I've stopped your video. I think we can see the slide.
Yes, that's enough. And this is the way we are going to do it. I'm enlarging so that you can see the writings.
Yes.
Subcortical endophenotype means behavior of subcortex in a particular area. Here, the subcortical endophenotype we currently are focusing on is blunted striatal response to incentives. That can happen due to environmental influence, means TBI, teratogenic exposure, hypoxia, they all can lead to this subcortical endophenotype. Then epigenetic regulation, vulnerability allele, all can give rise to this blunted striatal response to incentive. Now, if blunted striatal response to incentive happens, then it comes into either some exophenotype, which is trait anhedonia, irritability, and it can go into two type of different behavioral bias. One behavioral bias is reward seeking, that is active avoidance, passive avoidance. Now, which would be preferred depending on other endophenotype? Means, let's say there is another endophenotype which is strong amygdalar reactivity to danger. It also gives anxiety, but along with that, it also gives high state sensitivity. And when it combines with subcortical endophenotype of blunted striatal response, then we get immobilization as behavioral response. Now, there is another cortical endophenotype which is prefrontal dysfunction, which already has various other things. It create behavioral bias in emotional dysregulation, poor executive control, and when we get attention deficit picture, when we join behavioral bias B, we get unipolar depression picture. So this way we can unconstruct these various DSM-ICD names, and we can find out the specific traits or specific endophenotype that is behind each of them. It would take time, but meanwhile, we can give patient a understanding that, Dekh bhai, तेरा जो है, जो हम लोग डायग्नोस कर रहे हैं वो जस्ट बिहेवियरल सिम्टम है, यानी कि डिप्रेशन नाम का कोई बीमारी नहीं है. डिप्रेशन इज आवर नेम, आवर गिवन नेम फॉर योर ग्रुप ऑफ सिम्टम. सिजोफ्रेनिया नाम का कोई बीमारी नहीं है, तेरा कोई सिजोफ्रेनिया बीमारी नहीं है. तेरा है इट्स अ फॉर्म ऑफ क्रॉनिक ब्रेन डिसफंक्शन, जिसका को हम लोगों ने सिजोफ्रेनिया के नाम से, तेरा प्रॉब्ली ये सब है. पेशेंट्स वुड फील बेटर, family would understand more, and the adherence to treatment and compliance with दवाई का, उमन का बीमारी का. If we communicate via this, that would actually make them more complex.
Okay. I think Bhaskar, we lost you again.
And more
I think we lost. Hello, Bhaskar.
कहाँ तक विशाल?
Yeah. We can hear you now. I think we got your point. I think the last 1 minute we couldn't understand. I think there was too much break, but we got the gist of the whole thing. Can you move to a better area where there's more? Maybe if you close the door.
The last one was if. Yes. I'm doing that.
Yeah.
Yeah. Now
better.
Yeah, door close हो गया था.
मेरा diagnosis ठीक था.
डोर क्लोज. हाँ, ठीक था diagnosis. अब क्या हुआ कि actually क्या हो रहा है? Actually the thing is our DSM and ICD system is adding a large extent to the stigma, because patient बोल रहा है कि मेरा मन में कुछ नहीं है, तो फिर मेंटल डिसऑर्डर को मुझे स्टैम्प क्यों दिया जा रहा है? पेशेंट सिजोफ्रेनिया से डर जाता है. नाउ इफ वी स्टार्ट गिविंग देम आइडिया कि अरे भाई तेरा ये सिम्टम्स है, वी आर टॉकिंग अबाउट सिम्टम्स, वी आर नॉट टॉकिंग अबाउट डिजीजेस, बिकॉज दीज डिजीजेस आर नॉट anything, they are just symptoms. These names are symptoms and we are treating the symptoms. Your disease is inside your brain, we don't know that their name, and it is okay because our medicine can treat the background dysfunction without knowing the name of the condition. ये बोल के हम लोग चल सकते हैं. This is the way to go forward.
Okay.
So with this, I end my boring lecture. With this, I end my boring lecture. Sorry for the interruptions. Actually, network में बीच में problem हो रहा था और कुछ नहीं.
Yeah. I think otherwise it was very fascinating, very motivating, very captivating actually. Not motivating, but very captivating. Demotivating, I should say, but captivating. So we can please I request our chairpersons to please come back. Start your videos. Amrit told me he may be traveling because he has to go pick up his daughter or drop the daughter. Dr. Kaushik is there, thankfully. Dr. Manasvi, I can't see you. If you are there, please come back. But ये question जो पूछा गया ना, ये जो question पूछा है, Dr. Jyotish Shetty is saying, don't fish for compliments, Bhaskar. It was very nice. Yes. So, but Dr. Sharik का जो question है वो काफी valid है, because आज की डेट में सारे पेशेंट्स तो सिम्टम्स गूगल करके ऑलरेडी आए होते हैं, तो उन्हें ये नई चीजें तो मिलने नहीं वाली, थोड़ा मुश्किल है. जैसे कि स्किज़ोफ्रेनिया नहीं है, ये है, तो और कंफ्यूज हो जाएंगे वो. पहले इतने कंफ्यूज है. That's the, because this is the churning process. This is churning process, right? we still have to arrive at some place. So I think that kind of flux is going on. So, so you're saying your patients take it positively?
Yes, मैं डायरेक्टली बोलता हूँ कि देख भाई, सिजोफ्रेनिया नाम का बीमारी नहीं, सिजोफ्रेनिया नाम का सिम्टम एग्जिस्ट करता है. तेरा सिम्टम को बुक में सिजोफ्रेनिया नाम से डिस्क्राइब किया गया है, बट यू डोंट हैव द सिजोफ्रेनिया डिजीज बिकॉज इज डजंट एग्जिस्ट. पेशेंट वो समझते हैं.
तो okay. And do they say, because their main question is दवाइयाँ कब बंद होगी डॉक्टर साहब? So you tell them it's going to be lifelong?
Yes.
Okay. सबका अपना अपना. Okay, fine. Dr. Sharik, you want to ask any further before I hand it over to the chairperson? You have a choice.
चेयरपर्सन आगे
आगे दो चेयरपर्सन तो आ गए, तीसरे को मैं मैसेज कर रहा हूँ. आई थिंक ही इज ट्रैवलिंग. मैं उसको बोलता हूँ. आई टेल हिम. Over to Dr. Kaushik and Dr. Mercy. Oh, can't unmute. Okay, wait. Let me see. Okay. Try now, Dr. Sharik.
हो गया इसलिए.
Can you unmute yourself? Okay, you
Yeah,
can.
now I can.
I think now it's
Dr.
working.
Manasvi, Dr. Gautam, go ahead, please.
Yeah, after you, please.
So right now, I think we can take a few questions, at least 3-4 questions. One is there from Samsung. It's decrease the symptoms, but are there any strong evidence for continuing of them? Dr. Bhaskar, there is one query from psychometry.
Can you
decrease
identify
the
your
symptom,
name?
but are there any strong evidence for continuation of them?
Medicines, there are multiple evidences that continuing medicine would stop the disease from progressing severely. Evidences. Continuing medication for lifetime, continuing medication for a long time. There are multiple evidences in various papers. If anyone wants lifelong medication in psychiatry, and search it in Google Scholar or Crossref or any other medical search engine. And
queries, comment. One from Dr. Hemant is very pragmatic. This is area in transition, and we'll need a lot of Rahul, how do we tell our patients that psychiatry currently doesn't have any permanent cure? Your opinion on permanency of cure?
There can no disease of body has permanent cure. There is interstitial lung disease, no permanent cure. Hypertension, no permanent cure. Diabetes, no permanent cure. Hypertriglyceridemia, no permanent cure. Hypercholesterolemia, no permanent cure. CKD, no permanent cure. Nothing in our body has permanent cure except for infection, and they do come back. So standing there, how can we give patients of brain permanent cure while brain is the main organ of that you have? We are nothing but a brain, a spinal cord, and 2 pairs of eye. Rest of the thing are actually is a biomechanical contraception that we are actually moving around with, and the whole thing can be replaced if the replaceable entity within us, that disease of that thing cannot be cured. how can we expect our main self, diseases of our main self, that can be cured? There is no way to say cure at this moment. But if every other medical discipline is okay with lifelong medication, why not we?
Yeah, that's actually a very good point. So I'll just first I'd like to thank Dr. Vishal and Dr. Manushree and the DPS for actually creating such a nice topic. And it's my pleasure, privilege to thank Bhaskar also for having such a nice deliberation. In a sense, what Dr. Bhaskar says is a inner angst and problem and anger and frustration that we all clinicians feel about how there is an over influx of classificatory system and so many diagnoses and nothing seems to match. That being said, it has to go into our collective consciousness that this is an imperfect system and there is a need to go forward. So in other ways that we are all trying perhaps best, politics is always complicating things, but it is through this friction and the voices that we raise that maybe something good will come out of it. That would be my take, and I would definitely expect and I'll definitely encourage other participants to come forward and talk to Bhaskar or talk to, DPS, Dr. Vishal and others about taking forward this issue. So I thank for the opportunity and I hand over, I think, Dr. Gautam for his final words before he hand it over to Dr. Vishal, sir.
Yeah, thank you so much. I think it has been well said that there are many things between which are intermingled, which need to be addressed, which need to be deliberated, and there has been a lot of pondering over that today, as we saw from the expertise of Dr. Bhaskar. And we also, at the same time, I'll just say what I said earlier also, that we, I think, are the only branch which looks it into totality rather than just looking at one dimension. And since we are over inclusive in looking into various dimensions, sometimes they might look that they intermingle and they lose the purpose for which they are. But actually, that dynamicity somehow gives it a very uniqueness uh, throughout. That is the reason why there may be overlap of symptomatology, there may be overlap because of the overlap. Since we go to the syndromal level, we say that the form has changed and hence we put the another category of diagnosis. But all in all, whatever endeavors which we are doing are definitely looking the patient first. And hence in that good spirit, we are evolving as what I say. Definitely, there are a few more things which need to be looked upon, and we need to go more biological. That's as per Dr. Bhaskar. Then that further will keep on continuing. Right. Over
Amrit,
to
I think,
Vishal. Thank
is
you,
back.
Vishal, for this opportunity here.
Thank you. Thank you for joining all the way from Jaipur. Amrit is back online. Thank God. Thank you. Amrit, there are a few questions. Do you want to take them before you end, if you want to engage? Dr. Ganesh has a comment, and then Dr. Hemant also.
Yeah, I saw a comment from Dr. Rahman. Diagnosis also serves the purpose of communication between researchers. That was what we discussed in the very beginning. But it's all what is schizophrenia in India should not be phobia in US. That's what the diagnosis system aim to make, and research at one place could be extrapolated to a different region in terms of treatment, in terms of what we are looking. So that was it. But when the very communication line is in question, the language is in question, you cannot tell that they are similar, because even if you look at schizophrenia in DSM and ICD, it was so different. Something was so lenient and something was this Nigerian criteria was so stringent. So you had more people in America being admitted for schizophrenia, and the percentage of people with schizophrenia was much higher. So again, it's just the way you think, and I think the whole endeavor is to make people understand that it's not as straightforward as it was in the past. Like Bhaskar was telling, there are a lot of context to the diagnosis. the social, cultural, political. He was emphasizing more on the political thing, yes, but there was an element to it also. And to end, I would always tell that this is one of the great presentations of Bhaskar. And he has put in a lot of effort. He was, and as always, we are all fans of Bhaskar and his methods, if not his methods.
No, not his methods. The knowledge, yes. That's pretty sharp. Right inside. Bhaskar, Dr. Ganesh has highlighted this. Is a very enlightening lecture. However, I'd like to clarify that when common people go to the doctor, they would like to know the diagnosis, whether it's physical or psychiatric. If you say that we are treating the symptoms and the diagnostic name is just for naming and we're not sure, the credibility of us and the credibility of the branch itself will come in question.
No, it is not. Because already our credibility is almost nil. Most people come to us for counseling. Most people say, Doctor Saab, आपके थोड़ा counseling कर देना. People, other specialty people refer to us for counseling. So nothing more disastrous can happen. Rather, it would give us more scientific credibility because we are saying this is a symptom, this is not a disease. Your disease is a genetic condition in your brain. We know something about it. If you want, we can say in detail, but we would advise you not to go for genetic diagnosis at this moment, because if we get genetic diagnosis after spending 6 or 7 lakh rupees, we would still give you same medication. We don't have anything genetic at this moment. Our drugs work at genetic level, but they are temporary manipulator. If we talk about this way, people understand it better and they actually stop questioning the diagnosis, because there is no diagnosis. They start asking how to get better and they stick to the medication. This is actually my personal experience for a long time.
Okay, thank you so much. Yes, Dr. Hemant, that is true. Not some physicians, most of the physicians discourage. That is all right. We're not bothered about that. Dr. Pankaj, we also have some senior psychiatrists here, Dr. Ashwini, Dr. Monica Chip, Dr. Neena Bora ma'am, if you're still around. If you guys want to, Dr. Veena Kapoor also I saw, a very senior psychiatrist again from Delhi. If you want to, please put your inputs, or anybody else wants to have input before we close the meeting. Dr. Paramjeet is also here. Paramjeet, if you want to have a go, if you want to add any comment or ask anything.
Not as of now, sir. Enlightening lecture. Happy to hear.
Thank you. Okay, so I take Dr. Ashwini or sir, you want to ask anything, Ashwini sir?
Okay, so my only concern is that this movement should gain momentum, and the more and more colleagues should be able to say Bhaskar is suggesting.
Should say, sir?
Should say what Bhaskar is suggesting when it comes
to... Bhaskar is suggesting. Yeah, okay. Okay. So you are in favor of the whole thing. Nice. Yeah. Thank you, sir. Dr. Monica, ma'am. Dr. Jyoti left, I think. Jyoti Shetty. If not, okay, over to Dr. Monica.
Yeah. Yes, I remember hearing Dr. Khan, M.A. Khan, bless his soul, he's no longer there. Yeah, from Hyderabad. Long time ago saying that, we need to treat the symptoms, forget the illness. And I was really impressed by that. And that was many years ago. And I've been doing a lot of that. So I can quite understand what Dr. Bhaskar is saying. And it's the symptom relief that is going to make the patient happy, not the diagnosis.
True. Right. Well-spoken words. by a seasoned practitioner. That's very true, man. That's all we do in private practice.
Yeah.
That's true. That's true. Dr. Pankaj, over to you for the closing remarks.
Yeah, thank you, Dr. Vishal. Good afternoon, all of you once again. And Dr. Bhaskar, as always, it was a really feast to listen to you. And although your ideas are, revolting at times, and I think they've revolutionized our psychiatry branch as a whole. And I could remember and relate your ideas with Dr. Akhtar. I heard him in Delhi Psychiatry Conference a few years back, and he was the same opinion. He said, I have stopped giving diagnosis to my patient long back. If somebody comes to me, I've thrown them out of my window. I don't want to stigmatize them or limit my practice to a specific area. Similar thought, so I can really relate to your thoughts to him also. So I can see a real big leader in psychiatry from India in making. I'm really lucky to have you over here, Dr. Bhaskar. Thanks for your enlightening thoughts. And although we all are really really stressed for India's win today, and your thoughts so heavy, nobody thoughts have given a lot of food for the day, to keep us busy. Thank you very much.
Yes.
And thank you all the chairpersons, Dr. Amrit, Dr. Manasri, Dr. Jeff Ames. You all were really wonderful having you all on Sunday morning, and really thankful for joining us. So thanks from DPS and the DPS family to all of you. Thank you very much. You have a great day and hope to meet you all again. And we hope India wins. We all cheer for it. Thank you very much.
Yeah.
Bye bye.
Thank you.
Thank you so
Bye.
much.
Thank you so much. Just one more minute. I just want to announce that we are doing 2 programs by DPS in the coming month in December. On 10 December, there's going to be an RTMS hands-on workshop at Fortis Memorial Research Institute, Gurgaon, FMRA full day workshop. Details will be out soon. And we're on 16th of December in VMMC, Dr. Manushri and Dr. Pankaj Verma at Safdarjung Hospital will be conducting a workshop on, if I remember correctly, research methodology and statistics from a team from Manipal will be coming. KMC Manipal will be coming to conduct it. So these are the 2 brief announcements I wanted to make before we end this call. So thank you, Bhaskar. Thank you, everyone, for joining. It was really enlightening. And looking forward to interact with all of you again. Thank you, Doctor.
Bye bye.
Thank you.
Thank you. Thank you so much for
Dr.
inviting.
Kaushik.
Thank you, Bhaskar. Thank you, Vishal. Thank you, Pankaj. Thank you, everybody from DPS.
Thank you, everyone.
Thank
And
you.
नॉट जोन सेंटिमेंट याद रखना, एडिटर नॉट जोन से ही होना चाहिए.
Okay, thank you. Thank you so much. Okay.
Bye.
Bye.
Bye. All the
Bye,
best.
everyone.
Bye.
Bye.